So we're back to MSK, and we're going to talk about the elbow, and specifically MRI of tendon injuries. The objectives of this talk are to review the normal anatomy of the tendons and ligaments. We will only be talking about tendon abnormalities of the elbow. Here we go. So we're going to look at the anatomy as well as the MRI findings of tendon injuries. And specifically, we look at biceps tendon, triceps tendon, common flexor, and common extensor tendons. So I hope you had your coffee. There's a lot to cover, okay? I'm not covering ligament abnormalities. One way to think of elbow anatomy is divided into 4 compartments: anterior, medial, lateral, posterior. So what do we have anteriorly? We have biceps tendon and brachialis. Okay, brachialis is a muscle that sits directly on the humerus, so right in front of the bone. Then posteriorly, we have triceps, and we have anconeus muscle on the radial side. Medially, we have our flexor tendons, and laterally, our extensor tendons. So if you know this is there's a simplified way to look at the anatomy, but it's very practical and useful. These are the flexors and extensors. You most of the time don't need to know them individually. So in the extensors, there's a superficial group listed here, and then the common extensor tendons proper, and then you've got supinator, and flexors are listed here. There's also pronator teres on the medial side of the elbow. Okay, so now that we know this, let's talk a little bit about the biceps tendon. The distal biceps tendon is a flat tendon, shown here between the arrows, that forms about 7 centimeters above the elbow joint. As the tendon courses distally, it moves obliquely from anterior to posterior and from medial to lateral. And it also twists 90 degrees such that its anterior surface faces laterally. Its attachment on the radial tuberosity, which you can't see here, but it is wide and includes distinct footprints for the short and long heads. The biceps tendon also attaches to the lacertus fibrosus, shown here, which is a fascial expansion, shown in this Netter diagram, that passes towards the ulnar side to blend with the deep medial fascia. Okay, so what it does is it reinforces the antecubital fossa protecting the brachial artery and median nerve, which run underneath. And if the bicep tendon ruptures, like why are we talking about this? If the bicep tendon ruptures, and the lacertus fibrosis may prevent proximal retraction of the tendon and masking the clinical findings of a complete tear. And this is something we can help with as radiologists. What does the normal biceps tendon look like on MR? Here we see it on the axial image. Low signal intensity attaching on the radial tuberosity. And we see it on the sagittal. So here we have it attaching on the radial tuberosity, sagittal and T2. So most of the time we are looking at it on the axial image. Okay, so here are the lesions we typically see at the biceps: tendinosis, complete tear, partial tear, cubital bursitis. So let's look at examples of these. Tendinosis, like tendinosis anywhere, we have the signs on MR listed here: tendon thickening, some signal heterogeneity, so this is quite a bit thicker than the last case I just showed you. And tendinosis, like anywhere else, may be associated with partial tears, and in the elbow with cubital bursitis. What is the cubital bursa? It lies between the distal biceps tendon and anterior cortex of the radial tuberosity. Here it's shown on this enhanced image with fluid in the bursa. So it reduces friction between the biceps and the bone. And it actually is technically a bicipital radial bursa and interosseous bursa. And they may communicate. If it's normal, we don't see this bursa. So this is clearly abnormal. Interestingly, when it's this big, it can lead to compression of a branch of the radial nerve called the posterior interosseous nerve, or PIN, which is sitting right here. You could see how if you expect, there's something sitting there, a space-occupying lesion, it can compress this nerve. That has its own clinical presentation. So here's an example of bursitis, where on the sagittal we see fluid in this bursa. So again, no tendon sheath here. The biceps does not have a tendon sheath. Distally, it has a bursa. So fluid in the bursa on the sagittal and on the axial images. The differential diagnosis, just looking at this image, is listed here. So repeated trauma is the most common. A mechanical cause is the most common cause of this. Inflammatory arthropathy, because it is a bursa. Infection can affect this. If you have a bony proliferation, let's say from an old radial fracture or even ulnar fracture, you can get a mechanical cause in that sense of irritation of the bursa. Finally, synovial chondromatosis as well can affect this bursa. Just to go back, inflammatory arthropathy. So we have seen cases of rheumatoid arthritis with bursitis of the cubital bursa. So something to keep in mind if somebody has a history of it. Let's talk about biceps tendon rupture. So most biceps tendon rupture are of the long head proximally due to rotator cuff disease, like we briefly touched on. The distal ones where the tendon detaches from the radiotuberosity, that's the usual case, are less common. Myotendon is really rare. Males, more common than females. They just lift heavier things, and that's how they hurt themselves, typically. 40 to 60 is the classic sort of patient who comes with this dominant more than the non-dominant arm for obvious reasons. So history is typically a sudden extension applied to the elbow when it's a 90-degree flexion. So, and apparently these little bicep curls right around that 90 degrees is the best way to develop your biceps, FYI, as shown by. But so typically you're in that position, but your weight's too heavy and your arm lets go. That's how you tear your biceps tendon. And patients will say, I felt a pop and acute pain. This was out of order. This is the old version again. This was a case of rheumatoid arthritis with distension of the bicipital radial bursa. Just wanted to show you a companion case of a non-mechanical cause. This is rheumatoid. So inflammation, pannus, affects synovium and bursae. Well, bursae are lined by synovium, so it affects synovial-based processes can affect it. So back to bicep tendon rupture, physical exam, diagnosis, you have that classic Popeye sign where the biceps muscle belly really bulges more than usual when it's retracted. And you usually have bruising, okay, black and blue, and weak elbow flexion, though not absent because there are other muscles that perform elbow flexion, okay? And same for forearm supination. So even with a complete tear, you don't completely lose your elbow flexion. When do we image? Well, if you have a Popeye sign, a good clinician, you don't need to image. That this is especially useful if the tear is partial or non-retracted, so when you don't have the Popeye sign. We do want to identify these fairly early because surgical reinsertion should be performed early before you have scarring of the biceps. Here's an example. Typically, we start by looking at the axial images. We follow the biceps tendon. It's already looking very thick because it's retracted. Lots of fluid around it. Here, just showing you that it's supposed to insert here on the radial tuberosity, and it's not. There's nothing here. So, and then on the sagittal sequence, we can see the tendon retracted all the way here. So I try to measure the tendon retraction. This is that FABS view. We don't do it at our clinic. Flexed elbow, abducted shoulder, external, or forearm supination, sorry. So that's when basically it's like kind of like this. And so you're coronal to the bicep tendon. It makes it easier, but anyway, I happen to have a FABS view for this case. The tendon is all the way here. This is no tendon, nothing attaching. So it really makes it easy to measure, but you don't really need it. It just makes it easier. What's the role of MRI? Again, not necessary in confirming cases of complete biceps tears with the typical history, the Popeye sign. It's useful in more subtle clinical presentation. Again, the reasons we mentioned, and in post-op evaluation. I'll show you an example of that. So this is a 55-year-old male, acute pain after lifting his grandchild. So didn't have the Popeye sign. When we did the MR, we see that the biceps tendon is avulsed from the radial tuberosity. There's fluid.